Hello everyone, welcome back to Well Mind Study, where we discuss all things therapy related. The topic of today's video is when should you consider going to individual therapy? The point of this video is to provide viewers with a framework and language to use that may be helpful when considering if mental health services are wanted or needed. So for today, we're going to focus on 3 common issues that are addressed in therapy that could be useful for you or a loved one to consider. Those 3 factors are resourcing, behavioral modification, and emotional support. Please keep in mind that therapy can address all of these factors at once and often does, but we'll speak at length in this video about them individually to help prospective consumers of mental health services find language to use that may be helpful in deciding whether or not they want to engage in services. Resourcing. When we talk about resourcing here, we're talking about resourcing that addresses a myriad of needs, whether that be physical, psychological, communal, academic, romantic, etc. This resourcing can address chronically underserved needs that someone may have, including food scarcity, access to medical or psychiatric services, disability services such as transportation and in-home care, to name 2, or other services that many might not know are out there or that they're entitled to. Now, this is where case management and therapy overlap pretty significantly, and the work can feel pretty similar between the 2 providers. Where they may diverge depending on what case management encompasses at a particular agency is that, generally speaking, case management focuses on building rapport, resourcing, and stable relationship building, while therapists would focus on doing the same aforementioned tasks while assisting clients with recovering from their mental health symptoms. It's important to note that depending on the size of the caseload, some case managers may focus strictly on providing informational access to resources, while some therapists might solely focus on how lack of access to resources affects their clients' mental health. There is generally not a singular style that's practiced across the board, but personally, I appreciate it when a clinician is able to not only be knowledgeable about accessing community resources, but is able to give their clients a gentle nudge towards them in service of their treatment plan goals. Another note here is that some clients may form healthier and more therapeutic bonds with their case managers as opposed to their clinicians. So having both work with mental health consumers can be incredibly beneficial, as it broadens and enriches the work in ways that are just not possible with a single practitioner. Emotional support. Going to therapy for emotional support can be temporary or long-term with a provider that may be dictated by the reasons one is seeking therapy out to begin with. For example, if I'm having a hard time grieving the loss of a loved one, navigating a major life stressor, or having difficulties with other major life tasks, I might seek out therapy on a temporary basis to help incorporate these stressors into my life in a way that feels constructive. On the other hand, if I'm looking to receive emotional support through stressors that are going to feel more constant, such as relationships with dysfunctional or abusive communication patterns, life transitions in and out of disability, and intense job-related stressors, to name a few, I'm going to want to talk to my provider about what feels reasonable with respect to my treatment plan goals and where I want to be. An example of this conversation could look like someone receiving emotional support and learning how to cope with the stressors of their chosen profession, while someone else might want to talk through their reasons or rationales regarding staying or leaving a relationship with harmful dynamics or dysfunctional communication. This kind of therapy generally explores the client's history, motivations, and feelings about their circumstances while taking a non-judgmental approach in support of decisions the client may want to make for themselves regarding the distress they endure. When we talk about someone's motivations to engage or disengage from people or systems that exacerbate their mental health symptoms, then we usually end up enriching that person's perspective of themselves and helping them provide context as to why they may be making decisions for themselves that on the surface may appear unhealthy. Insight work and behavioral modification. Regarding decisions that may appear unhealthy, behavioral modification is often a pretty significant reason many seek therapy even when there's no intent to change when first starting services. Some therapies, such as solution-focused therapy or cognitive behavioral therapy, may address modifications in behavior from the first session, but in my experience with many clients, what they're looking for is often to understand the whys and hows of their psychological processes before committing to changing their behavior. This approach in itself can be helpful, and we're going to demonstrate how with the following vignette. Please note that the vignette I'm using here is strictly for demonstration purposes and does not use identifying information or details from anyone I've practiced with. Ramon is a 25-year-old cis heterosexual Mexican male that presents for services with initial dual diagnosis of generalized anxiety disorder and major depressive disorder, moderate, via his intake. After a few sessions with the clinician, Ramon opens up about his childhood, where he describes every day as hell in waiting, noting that he would be physically abused by one or both parents when they were drunk. Ramon states that this happened roughly from the age of 7 all the way until he was 17. Ramon describes moving out at 17 as feeling like I was on cloud 9, despite the stressors of having to navigate adulthood on his own. Ramon went no contact with his parents, and for approximately 2 months after moving out from their shared home, he reports that his mental health was probably the best it had ever been. Despite this, Ramon reports that he began to have night terrors after these 2 months, in addition to severe anxiety, panic attacks, depressive thoughts, and difficulties experienced with negative thought cycles. Ramon reports that these stressors mostly subsided after he began drinking by himself. Ramon adds that while he doesn't drink to get drunk, he is somewhat troubled by the fact that his drinking has become more frequent and greater in volume when he does drink. Currently, Ramon has 5 to 6 drinks every other night and struggles with withdrawal symptoms when at work or when trying to socialize outside of bars. Now, while Ramon initially presented with symptoms of generalized anxiety disorder and major depressive disorder, I'm going to want to ask some clarifying questions to see if he meets criteria for post-traumatic stress disorder, considering his family history, and alcohol use disorder, considering the frequency of his imbibing and these withdrawal symptoms. While Ramon's symptoms have improved somewhat, I'm going to entertain the idea that alcohol may actually be used as a coping strategy to mask symptoms of the trauma he's endured. Coping strategies need not be healthy to be effective, so it's going to be important to gauge whether or not Ramon sees his alcohol usage as a problem. And here's where the two approaches to this could land. If the clinician suggests to Ramon that he stop drinking, start exercising, start socializing with friends, and start considering his long-term goals for his life as part of a behavioral health program, Ramon could take this advice and start feeling some relief from his symptoms. On the other hand, the risks of this approach do include a potential death from alcohol withdrawal and replacing alcohol usage with another easily accessible drug or behavior that further places Ramon's physical or psychological health at risk. On the other hand, if Ramon has the capacity to consider the motivations that led to his drinking behaviors, then he could gain the insight needed to begin planning what he wants for himself in the short and long term. If we're to confirm a diagnosis of post-traumatic stress disorder and a potential diagnosis of an alcohol usage disorder, Ramon could very well talk to his primary care physician to gauge the appropriateness of a medical detox or inpatient rehab program to address the function of alcohol usage, as it could help keep Ramon in a heightened state of distress while withdrawing that feels physiologically similar to the environment that he was accustomed to that produced his PTSD symptoms in the first place. So, how does this relate to behavioral modification? While recovery from post-traumatic stress disorder or other traumas may not be as quick as we'd like, Ramon could stand to benefit from examining his current behaviors to see what keeps his nervous system elevated to a level that exacerbates his symptoms. Ramon successfully replicated the feeling of hell in waiting through his drinking behaviors and worked towards finding replacement behaviors to not only help him cope in ways that soothe his nervous system, but also give him an outlet when he feels the need to release some of the pent-up agitation that he experiences as he works through therapy. While we've gone over 3 factors that you can consider when deciding whether or not to go into therapy, I'd be curious to know what your thoughts are. If you'd like your voice added to the conversation, feel free to leave your thoughts in the comment section down below. Thank you for joining us today, and I look forward to seeing you next time.